Very good.
And now you're recording. Good luck.
Um, Good morning, Senator Kalaj. Many thanks, Dr. Kingsley Baskararaj, and many thanks for the Merck Foundation for inviting me to give this presentation. I will now start sharing, and I will share my presentation. I'm asked to talk about lung fibrosis. My name is Dr. Nabil Jarad. I'm a consultant physician at Gloucester Royal Hospital. And as I said, I will share to you my thoughts about lung fibrosis. This is the hospital, which is two parts. The first on the left is the Gloucestershire Hospital, and the second one on the right, it is Cheltenham General Hospital, and these two sites are part of the same hospital. Lung fibrosis initially thought to be an uncommon condition, but we, as respiratory physician, see it not infrequently. The prevalence or the epidemiology is around 75 per 100,000, and this is about interstitial lung disease, is not include post-TB fibrosis. There are several types of interstitial lung disease. The commonest is what we call idiopathic lung fibrosis, or we call it sometimes usual interstitial pneumonitis. We call it UIP, and non-specific interstitial pneumonitis, and I will make the distinction in a minute. And the prevalence of that is about 30 per 100,000. Sarcoidosis, which is perhaps commoner in your part of the world, and is about 12 per 100,000. And there are other lung fibroses associated with connective tissue disease, which is less common. And the two conditions I would like to cite are rheumatoid arthritis and systemic sclerosis. For all interstitial lung disease, the cardinal test is high-resolution CT scan. You may be guided to it by looking at the chest X-ray and listening to end inspiratory crackles by auscultation, but the confirmatory test is high-resolution CT scan. It is difficult to know where the process of lung fibrosis starts, but it is generally accepted that a lung injury, often it is an infection, happened to start with. The non-fibrotic stage of the disease comes into various inflammatory changes. And this is particularly important. The non-inflammatory or the non-fibrotic change can be treated or can be stopped by a variety of medications, which are anti-inflammatory and immune modulators. However, when the inflammatory is followed by fibrotic changes, the treatment currently does not reverse the condition, and the importance of the treatment is to stop the fibrotic changes from progressing and from engulfing the lungs. So the inflammatory non-fibrotic change can be treated and can be reversed, but the fibrotic change can be treated, and the main aim of the treatment is to stop the decline in lung function tests. I would like now to go into the variety of usual manifestations of lung fibrosis, and for every type of lung fibrosis, we look into the clinical side, prognosis, management, and the likelihood of prognosis to death. As I said, the commonest condition is idiopathic pulmonary fibrosis, and this is a disease of the elderly. It starts often after 50 years of age, and in fact, in our neck of the woods, starts normally after 65 years of age. It is a male predominant disease seen in people who smoked or are current smokers. On CT scan or on X-rays, it mainly affects the lung bases. Not everyone has finger clubbing, but it happens in a proportion of people. It has a poor prognosis. Most people die within 3 to 4 disease. People who hold poor prognosis is when the diagnosis is in old age, in male, and when people have a well-established lung fibrosis, the so-called honeycomb manifestation and the traction bronchiectasis. These will be indicating a poor prognosis. The management of idiopathic lung fibrosis is smoking cessation, management of breathlessness with opioid anxiolytic agents like diazepam, and with oxygen therapy. Even with the development of modern treatment, this is really the gold standard of treatment of lung fibrosis, managing symptoms and providing oxygen therapy. Antifibrotic treatment, I will be talking about that, and I'll be talking about pirfenidone and nintedanib. Cough management and fatigue management is important. We refer people for the same pulmonary rehabilitation program that will refer our COPD patient. We seek palliative care input for a holistic management of the patient. Proportion of patients who go to death with usual interstitial fibrosis is very high, and people die within 3 to 4 years. This is the commonest form, and this is perhaps this slide particularly would summarize the major manifestation and major management of the disease, which is the commonest and the disease that carries worse prognosis. Interstitial lung disease associated with rheumatoid arthritis normally is seen initially in people who have a manifestation of rheumatoid arthritis, normally deforming, but not necessarily patient with rheumatoid arthritis. Some people say that lung fibrosis precedes this group of the joint manifestation, but this is not quite clear. The chest changes is very similar to the previous condition, except that it tends to happen in the apices and on the bases of the lungs. It has more ground glass opacities, something we call non-specific interstitial lung fibrosis. So unlike the previous idiopathic lung fibrosis, which is a basal disease and tend to be well established, lung fibrosis and rheumatoid arthritis can have ground glass opacities, as you can see down here, and can have can happen in the upper part and middle part of the lungs. Prognosis is also in old age, if the manifestation, male predominance, if it has well-established manifestations like honeycomb formation, and if the FEV1 or the FVC is reduced below 70%. The treatment is to manage breathlessness and cough as we did in the previous disease. But unlike the lung fibrosis, anti-inflammatory treatments do work. In lung fibrosis here, anti-inflammatory treatment such as steroid do not work, and it is normally advised against. With this condition, prednisolone and methotrexate, mycophenolate, and azathioprine are of help. If the disease is well established, nintedanib will be offered. Unlike the poor prognosis in idiopathic lung fibrosis, proportion of patients who progress to death is much less at 30%. Interstitial lung fibrosis associated with systemic sclerosis have many similarities with those with rheumatoid arthritis. You have manifestations of lung fibrosis with fine crackles, but also manifestations of systemic sclerosis, such as skin changes. This is tightness around the joint, Raynaud's phenomena, vasculitic changes, and gastroesophageal reflux disease because of the disease affecting the esophagus. The chest imaging is very similar to rheumatoid arthritis, is non-specific interstitial pneumonitis, as you can see. The prognosis is a lot better than previous condition. The 10-year survival, nearly half of the populations. The predictor of progression to death is black race, male gender, impaired lung function test, and some antibodies factors. If the people have severe lung changes, and if they have pulmonary hypertension, which can happen with or without lung fibrosis, these are all poor prognostic factors. The treatment is mainly really anti-inflammatory treatment. We give mycophenolate, azathioprine, rituximab, and tocilizumab. And if there is a fibrosis, nintedanib is proving to reduce the decline in lung function test. Only 40% progress to death. I would like just here to make the comment that methotrexate and azathioprine are now thought to less likely induce lung fibrosis themselves. So if you find a person with lung fibrosis and on methotrexate, it is very likely that the condition is the cause of lung fibrosis rather than the drug itself. Sarcoidosis is a unique condition, and unlike previous condition, the presence of fibrosis and changes of fibrosis tend to be very inorderly. So unlike the subpleural fibrosis and interstitial here, the fibrosis tend to be much more of a conglomerate fibrosis affecting the upper lobe, causes traction bronchiectasis, cystic changes, and pleural cap. As you can see in this X-ray, with burnt out fibrosis or sarcoidosis, there are calcifications affecting the lymph nodes, something we call an egg shell manifestations. The prognosis is reasonably good because there are preservation of good parts of the lungs, and the predictor of prognosis, poor prognosis, is the black race. The management in the majority of people is to monitor patient, and corticosteroid, azathioprine, methotrexate, and rituximab can be given in people who have active sarcoidosis rather than in people who have burned out sarcoidosis. Proportion of patients who go to death is 1 in 6 approximately. The condition of hypersensitivity pneumonitis is of a great interest in the UK. It used to be called fibrotic hypersensitivity pneumonitis, or sometimes we call it extrinsic allergic alveolitis, which is really a misnomer of this condition. And clinically, with the history, there is a prolonged exposure to known agents. However, in some patients, and that's very important to note, that there are no known agents. Patients come with upper lobe disease and radiological manifestations, but there is nothing in the history to indicate what kind of agent there is an exposure to. It is an upper lobe disease and has ground glass opacity before it becomes fibrotic. The prognosis is quite good normally. However, if there is no known agent and if the disease is progressive and if there are fibrotic changes, these are all a predictor of progressive to death. The management, if you know the agent, avoiding of exposure. In the UK, this is the hardest bit, especially if the exposure is a cockatiel or bird of paradise or pigeons. Um, People may will find it very hard to avoid them. Anti-inflammatory agents are the next step, and nintedanib is good for progressive lung fibrosis. And very, very few people die from extrinsic allergic alveolitis. So by and large, it is a treatable disease. Finally, the other type of fibrosis is the so-called unclassified, non-specific interstitial lung disease. It's a disease of the upper airways. There is no factor you can identify. It can cause fibrosis, but in the majority of people, you found ground glass opacities. And the ground glass opacities, in general, on CT scan, is a treatable condition with anti-inflammatory medications. And the treatment is often supportive. You can give antifibrotic treatment when there is a well-established fibrosis, and both pirfenidone and nintedanib are effective. When do we do bronchoscopy to make a diagnosis of lung fibrosis? Given bronchoscopy now become extremely rare to make a diagnosis, CT scan is sufficient. However, bronchoscopy can be indicated in patients who have unclear diagnosis. If there is a possible infection like this, or possible cancer, which is not an interstitial lung disease, but fibrosis can be used to either take a biopsy or to quantify cell content, which will predict the response to steroid. So in bronchoalveolar lavage, the higher the lymphocytes, the more likely that the patient might respond to corticosteroid, provided that the patient has interstitial lung fibrosis rather than cancer or an infection. Transbronchial biopsy, it can be employed to take a sample, and sometimes thoracoscopy and lung biopsy can be employed in patient when the manifestations are unclear and when there is a clear need to take a biopsy to rule out treatable other conditions such as infection, cancers, or granulomatous lung disease. Nowadays, cryobiopsy is a form of biopsy that can be employed to take a big sample of the lung, and the cryobiopsy is have the advantage of taking a big sample compared, this is transbronchial biopsy. It has the complication of bleeding, but on the whole, cryobiopsy, if it's employed, it can take a big chunk and it is relatively safe. I would like now to move on to the treatment. And I would like to start with the study that called the Panther study, in which have really changed our practice in patients who have idiopathic lung fibrosis or usual interstitial pneumonitis. In the Panther study, which has been published now about 14 years ago, there was a 3-arm in which in arm 1, prednisolone, azathioprine, and N-acetylcysteine were given. Arm 2, N-acetylcysteine given alone, and arm 3 was placebo. The study has stopped halfway through because of safety reason. Arm 1 and Arm 3 were compared, so this is the combined therapy with placebo, and they were found that mortality rate and progression to hospitalization was a lot higher in people who had been given combined treatment compared to placebo. And in here, this is the bottom graph on the right, time to death and hospitalization was immediately higher in the combination therapy compared to placebo. And that means that people should not be given prednisolone, azathioprine, and N-acetylcysteine alone. Can I say that the combination therapy and the completion of the Panther study has found that in arm 2, N-acetylcysteine was ineffective in patients with interstitial lung disease. So currently, there is no anti-inflammatory treatment to people with well-established idiopathic lung fibrosis. A supportive therapy, as I said, it is hopefully available everywhere, is probably the cornerstone of treatment of the majority of the lung fibrosis. Cough can be given, and the cough can be dry, hacking, and sometimes it actually produces thick and tenacious sputum. Dextromethorphan containing cough linctus can be given. If people have colored sputum, a course of antibiotics can help. Breathlessness can be treated by either oxygen therapy, opioid, or anxiolytic agents. Pulmonary rehabilitation can reduce breathlessness, but only for a short period of time. The other two symptoms are fairly resistant to treatment, and that is fatigue and weight loss. And currently there is no treatment present, and the only thing will be an adjusting activities to adjust for fatigue, and weight loss is for an attempt of high calorie nutritional therapy. What about antifibrotic treatment? Antifibrotic treatment is fairly expensive, and the main aim is to reduce the decline in lung function tests. In the UK, all patients with interstitial lung disease are discussed with the information available to them in specialist center by a multidisciplinary team meetings where a respiratory physician, radiologist, physiotherapist, and nurses, as well as pharmacists, are present. And the drug is provided by certain centers and by followed up by the central pharmacist to ensure that compliance is achieved and side effects are monitored. In the UK, forced vital capacity need to be between 50% and 80% of predicted, or it has a rapid decline of 10% within 1 year. Normally, it does affect the decline in lung function tests. The common side effect for pirfenidone is photosensitivity, and for diarrhea, for nintedanib is diarrhea. And we give people some precautions of that, as I mentioned in a minute. Pirfenidone is 200 milligrams twice daily, and it does cause photosensitivity. And we advise patients to wear protective clothes, sunglasses, and sun cream, and not to expose to the sun. But as you can see in people who are susceptible, there is a prevention of decline or slowing down in decline in vital capacity. And this is the original study in 2016. The solid bit is pirfenidone, and the light bit is placebo, and there is a difference, and the difference is encountered after 3 months of providing the treatment. Nintedanib, if you remember the cycle of pre-fibrotic and then fibrotic phase, is another mode of action, is initially anti-cancer treatment, and nintedanib can stop the non-fibrotic phase of becoming fibrotic. So it acts as an anti-inflammatory, but it also can stop fibroblast from producing fibers. So it does slow down the fibrotic changes, and it slows down the decline of lung function test by this particular phenomenon. As I said, the main side effect is diarrhea, and often this group of people are given medications such as Imodium as a protective agent and as a standby agent if diarrhea happens. And like pirfenidone, it does slow down the decline in lung function test. This is nintedanib. This is compared to placebo. And the dose either 100 or 150 milligram twice daily. The same effect is seen in systemic sclerosis and in patients with fibrotic component, irrespective of the cause of lung fibrosis. And that is very encouraging. So we can give antifibrotic treatment even if we don't know the cause of fibrotic changes, and even if the patient has all kind of um, u- usual interstitial fibrosis like fibrotic changes. So can be given freely to all people with lung fibrosis. When do we give prednisolone in interstitial lung fibrosis? We give it in non-specific interstitial pneumonitis, and when the CT scan show ground glass abnormalities. So it's not well established it's not for well-established lung fibrosis. This is my view of how to start. Steroid is to start 40 milligram once daily for 4 weeks, and after that, reduce it quickly by 10 milligram every 2 weeks. So after 4 weeks, people start on 30 milligram for 2 weeks, then 20 milligram for 2 weeks, then 10 milligram as a maintenance dose. Reducing the dose below 10 milligram, and especially in responders, need to be done fairly carefully and need to be monitored by symptoms, lung function tests, and by radiological investigations, such as chest x-ray or preferably CT scan if available. If relapse happened after tapering the medication, then methotrexate and azathioprine can be considered as steroid-sparing agents. As I said, methotrexate and azathioprine are often unlikely to cause fibrosis themselves. An important component on lung fibrosis, and that is gastroesophageal reflux. This is a patient with lung fibrosis and hiatus hernia, and the hiatus hernia will dribble over the lung and often exacerbate lung fibrosis. That happens even in patients who are using proton pump inhibitors. So it happens even if the juice of the stomach is alkaline rather than acidotic, because pepsin can still go up and damage the lungs. And the treatment here is fairly hard. It is not recommended that surgical treatment can occur except in exceptional cases. And then here there is something called fundoplication, and that is kind of increase the strength of the esophageal abdominal foramen. But that is not something we use routinely. And the only thing we use is proton pump inhibitors on the hope that suppression of the acid will reduce the potency of pepsin of damaging the lungs. I would like just to finish by exacerbation of lung fibrosis. And this is a phenomena that we see in an acute environment. It is a serious complication. It's often induced by infection. A patient who is known to have lung fibrosis presents to an emergency department with acute increase of symptoms, breathlessness, cough, and fatigue. This diagnosis can be supported by new X-ray changes or CT scan changes, as you can see here. And often we have elevation in inflammatory markers such as ESR or CRP, as we do in the UK. The treatment of exacerbation of lung fibrosis is a supportive treatment by giving oxygen therapy in hypoxic patients. We normally start antibiotics, either intravenous or orally, depending on the compromise of the lung fields. The treatment is continued after discharge for 2 weeks with antibiotics. Any antibiotics will do. Prednisolone is given 30 to 40 milligram for 2 weeks. It is possible to give methylprednisolone during the acute stage in compromised patient. If patient need assisted ventilation or an intensive care, the prognosis is poor. You may wish to consider it if you feel that the patient have reversible component, but if the patient needed assisted ventilation or intensive care, it often carries a very high mortality rate. COVID can cause lung fibrosis, but unlike what was thought before, the COVID lung fibrosis is very rare and is often associated with people who needed intensive care at the COVID period. COVID pneumonitis tend to be much more of ground glass opacities rather than well-established lung fibrosis. However, the disease is milder than what we thought, and often lung fibrosis can respond to treatment or resolve by its own. This is a patient with fibrosis with pneumonitis after COVID. And as you can see, there is widespread ground glass opacities. And they were treated, but 6 months after the treatment, only basal changes remain. And as you can see, the ground glass opacities have disappeared. Pirfenidone has been tested and nintedanib has been tested, but there are no solid criteria about their efficacy. Of course, you can start it if the patient have impaired lung function test and if there are no other treatment available. So I'll finish, ladies and gentlemen, with the conclusion. Lung fibrosis remains an unpleasant respiratory illness with potentially high impact with breathlessness, disability, and cough. The diagnostic procedure remained high-resolution CT scan of the lungs. The mainstone of the management is supportive, normally cough, breathlessness, and oxygen therapy. The prognosis is variable between types of lung fibrosis, but it is generally poor for idiopathic lung fibrosis. We talked about exacerbation of lung fibrosis being a serious complication, but actually potentially treatable. And again, the treatment is with oxygen, antibiotics, and short course of steroid, normally 2 weeks. Antifibrotic treatment are available and promising, but they don't reverse the disease. It's given to people with impairment of lung function tests and with fibrotic changes. Thank you very much, ladies and gentlemen, and I hope to be present when the time for question and answer, but that will depend on the technology and with the ability to communicate. Thank you once more.